Yes, let's start. Thank you everyone for your patience. This is obviously new territory. So again, I want to thank everyone for joining us today.
This is when we usually start, Scott.
Exactly, it's true. We usually have food in front of us at this point. I'm Scott Podolsky, and I normally coordinate our department's in-person seminar series with Jen Pusetti and Carol Benoit. And in the setting of the COVID-19 pandemic, we thought that now, more than ever, we need to think through a social medicine lens regarding who gets sick, what meaning we ascribe to such illness, and how we respond individually and collectively. Last Thursday, we heard from Megan Murray, Louise Ivers, Vanessa Carey, and Paul Farmer concerning what we know with respect to COVID-19, the inequalities the pandemic exposes and exacerbates, and the types of responses that could and should ensue, not only with respect to coronavirus, but with respect to strengthening health systems and making them more equitable moving forward. Today, we focus more specifically on the mental health consequences of COVID-19. The virus and the disruption it has generated have a demonstrated ability, at the very least, to engender tremendous anxiety among patients, caregivers, and those socially distancing. Once again, our department is blessed to have members who have been there before, and we're especially fortunate to have Giuseppe Raviola with us today. Dr. Raviola is an assistant professor of psychiatry at MGH, and within our department is assistant professor of global health and social medicine, director of the program in global mental health and social change, and director of mental health for Partners in Health. He has longstanding interest in the mental health of both caregivers and patients, and has been especially innovative in his approaches to the incorporation of mental health interventions within existing primary care and other healthcare infrastructures. He'll be followed by Paul Farmer, our department chair, who will serve as the discussant, and has likewise long turned his and our attention to the mental health consequences of pandemics and endemic disease alike. We'll then have time for questions and answers. As with last week, audience members can submit questions anytime through the Q&A button at the bottom of your screen. And I intend to sort through those and direct them to our speakers at the end. And I suspect we'll generate quite a few questions, so we'll get started now with Dr. Raviola.
Thank you, Scott, and thank you, everyone. I'm going to get my presentation started. So, there we go. So I really appreciate the opportunity to be able to speak with you all, and I really hope that this is obviously just the beginning of a set of conversations, because the issues are so active right now. And I'm going to try to keep it to about 30 minutes. My slides I will share, and Carol will send them out, as well as the video. But we're all kind of on the back foot with this. And let's see. All right. We're all kind of on the back foot. And I'm pulling together information for myself while at Partners in Health, where I direct mental health. Our team has also been responding. So today I'm going to talk about essential aspects of pandemic mental health response as they relate to COVID. I'm going to describe some initial actions that we've taken and other global health delivery organizations have taken in planning an emergency mental health response. And I'm going to touch on basic self-care for the coming weeks and potentially months. I'm going to refer to the rapidly escalating urgency and social change that's occurring, and it's actively occurring hour by hour, and we're all living it. It's quite remarkable in terms of the global scope of this and the fact that colleagues and friends across continents are experiencing very similar things. I'm going to briefly touch on lessons from HIV, TB, and Ebola, which I'll leave it to Dr. Farmer to provide more context there, but I'll say a couple things. And some lessons from global mental health delivery, which is a field that I'm involved in with others in our department. I'm going to mention a few things about pandemics and mental health response, and I'm going to describe several aspects of the Partners in Health emergency response to date, both the long-term preparation that's gone on now for years, and our crisis response in collaboration with our sites, as well as positive coordination with global partners. Right now, we're actively experiencing tremendous loss of colleagues and friends. Many healthcare professionals, clinicians, teachers, and researchers are going to be affected. Already, we've had colleagues in Indonesia who have passed away due to COVID. We want to send our condolences and share solidarity with colleagues and friends here in the US and globally who are suffering and who are putting themselves on the front line against this new unknown enemy. We are experiencing rapid, escalating urgency and social change. Today in particular, it feels like a growing sense of foreboding, grief, and loss is coming to us. To others, to ourselves, our family, friends, and colleagues, we're all feeling a sense of powerless and loss of control. We're experiencing growing uncertainty about the short and long-term future, something like acute on chronic uncertainty. There's some hopefulness that positive change can come out of this global crisis and accompanying phenomena, and there's gratitude for our blessings. But we're all adapting to the reality of a pandemic future, potentially, and most likely. We also have some urgent problems to deal with in the short term to solve. Lack of protective equipment for medical and healthcare professionals in the US is an outrageous situation. The structural barriers to protecting medical and healthcare professionals must be removed, and I'll say a bit more about that. I'm sure Dr. Farmer will also say more about that. And last night, as I was putting this talk together, I was thinking these things, and then you can refer this morning to the New York Times. There's a nice little piece on grieving the losses of coronavirus. There's another piece, interesting, by Mark Lipsitch and Jonathan Grad from the Harvard School of Public Health, describing where we are. Imagine you're in a small boat far from shore. A surprise storm capsizes the boat and tosses you into the sea. You try to tame your panic, somehow find the boat's flimsy but still floating life raft, and struggle into it. You catch your breath, look around, and try to think what to do next. Thinking clearly is hard to do after a near-drowning experience. You do, though, realize two important things. First, the raft is saving your life for the moment, and you need to stay in it until you have a better plan. Second, the raft is not a viable long-term option, and you need to get to land. In April 2020, the storm is the COVID-19 pandemic. The life raft is the combination of intense measures we are using to slow the spread of the virus, and dry land is the end of the pandemic. I spoke with David Jones yesterday about the psychology of pandemics, and we were discussing the fact that we know so little. We haven't experienced major pandemics here in the United States like this. There have been pandemics over the past 20 years, 30 years. But interestingly, there is a whole psychology of pandemics, that there are parallel processes. One is that there are psychological processes that mirror the epidemiological processes that are occurring. And so as we feel this wave of COVID coming towards us and illness, psychologically, we're all experiencing something in parallel to that. Infectious disease also as an actual contagion, and mental illness as a symbolic contagion and a real contagion, and stigma and isolation due to fear of contagion and insanity exists for both of these, which makes it a particularly intense experience when we consider the mental health and psychological aspects of pandemics. The situation brings up unconscious primal reactions, fear, desperation, understandable anger. There can be a perception of the pandemic as punishment of communities for sins with ongoing search for causality. And we are all searching for deeper existential meaning with this disruption of reality and order in our lives. There's a whole contagion theory and emotional pandemic concept that has an emotional component and a behavioral component. There is a significant and understandable public demand for information, and we need to be aware of potential manipulation of emotional and behavioral reactions of the public for political purposes in the age of modern communication and social media. If 2007 was the year of the iPhone, then 2020 will be the year of startling technological transformation as a means of communication and transaction. We're also going to be asked to consider the endeavor of global health itself. There was a piece this past week in The Lancet, a brief piece. COVID-19 gives the lie to global health expertise. Global health will never be the same after COVID-19. It cannot be. The pandemic has given the lie to the notion that expertise is concentrated in, or at least best channeled by legacy powers and historically rich states. We must move quickly for our own security beyond the rhetoric of equality to the reality of a more democratic, more multipolar, more networked, and more distributed understanding and operation of global health. Conversations about how to do so, although just beginning, are long overdue. It's a very interesting thing, how we're flipping things on their head in terms of the place of centers such as the United States and Europe, who are most profoundly affected to date by this. I'm going to say a few things. Yesterday, there was a very nice piece on WBUR, The Way the US Beat TB Could Be a Boon in Battling Coronavirus, by colleagues of ours in our department, really talking about application of lessons from the care of tuberculosis by organizations such as Partners in Health in places such as Peru, Haiti, Rwanda, elsewhere, to develop strategies to manage tuberculosis. And this is a very nice piece that you can take a look at. It gets at this question of what we are to learn from other pandemics that have occurred. When I was a medical student at Harvard with Professor Mary Jo Good in the Department of Global Health and Social Medicine, we developed the first study of physician mental health in sub-Saharan Africa in the context of HIV. I spent a year working at Kenyatta National Hospital in Nairobi, Kenya. 150 patients per resident, 50 admissions on a call night, 2 patients per bed. In the morning, we would come into the wards, there would be 10 to 15 bodies in body bags in the attending areas between the clinics. What we found was a significant burden of depression and post-traumatic stress among these residents. And the very moral foundations of medicine as a scientific and caring profession were called into question by HIV/AIDS in various parts of the world, including sub-Saharan Africa and also in parts of the United States. Practicing medicine and training new physicians in such settings produced profound ethical dilemmas. And here you have some testimonies. This was a qualitative study with interviews of the physicians. The idea that there's nothing we can do here and hopelessness pervaded the experience of many of these residents. But what was telling was that the solution to physician burnout in the context of public sector medicine in sub-Saharan Africa was not prescribing an antidepressant. There were clearly structural measures that needed to be taken, tailored to context, to support the residents. And one of our findings from that work was that while HIV/AIDS was contributing to a demoralization of medical faculty and an erosion of fundamental intellectual assumptions about medicine as a system knowledge, so too was the culture of public hospital practice and the institutions under which students and residents train. Similarly, here in the United States and elsewhere with COVID, we need to look at the structural challenges and problems related to health systems and how those are compounding the problems that physicians are facing today in our country. Lessons from global mental health delivery. Well, global mental health delivery is a branch of global mental health, which is a branch of global health. Global health delivery entails the actual planning, service implementation, and sustained supply of comprehensive, integrated medical and preventive treatments to people living in resource-limited settings. In global health delivery, the mere existence of functional, sustained services can arguably at times be itself an innovation relative to care as usual, not just apps and other electronic tools. And this is particularly true in global mental health delivery because of a story that some of us know quite well, which is that mental health receives so little attention in terms of development assistance. If the global burden of illness is 15%, many ministries of health and governments globally give less than 1% of their budgets to mental health services. And there's a profound shortage of mental health professionals in low and middle income countries. But even in high income countries such as the United States, there's incredible disparity between urban and rural areas. And we need to keep that in mind. But what's really important is that the field of global mental health and global mental health delivery has tools that have been developed and tested that are relevant across high, middle, and low income countries. I just reference here some of the World Health Organization tools that are readily available: psychological first aid, MHGAP, the MHGAP manual for humanitarian settings. These are very important and helpful tools that I've shared some of them with you. And important to bear in mind that our department has been a major actor in the evolution of global mental health and global mental health delivery. Going back to the World Mental Health Report of 2001, there are people on the line here who were major authors of that, to the Lancet Commission on Global Mental Health and Sustainable Development from 2018, to new initiatives such as Global Mental Health at Harvard. We have courses, foundations in global mental health, case studies in global mental health delivery that I'm currently teaching. We just started 2 weeks ago with Professors Vikram Patel, Shekhar Saxena. We've had meetings with the Harvard Center for Global Health Delivery, Dubai, several meetings focusing on exactly the kind of conundrums and problems we want to solve as we move forward with COVID. And our course, in fact, is broken into 3 units, which are perfectly suited to this COVID crisis. The first unit is systems of care, where we think about how do we optimize the low end of this pyramid, self-care and informal community care, when obviously now with clinics closed and us limited to virtual contact, we have to support individuals and communities in helping themselves and helping each other. Unit 2 in the course focuses on humanitarian crisis. This is a process map of 10 years of work in Haiti, where we developed a comprehensive community-based mental health system. And here in yellow, I just want to note the emergency response phase, which is where we are now with COVID. So while we don't know yet what our process map for COVID-19 will look like exactly, we know that we're in this crisis phase and we need to plan accordingly for the long term. The third unit of the course is focused on task sharing. And task sharing, which is the mobilization of non-specialist providers to deliver mental health services, is a critical intervention that has proven evidence, that has not been taken up significantly in the US context, although, for example, nurse practitioners are prescribing medications here in the United States. That would be an example of task sharing. But we really need to take task sharing seriously as we think about COVID. We need to take seriously this concept of platforms of delivery as we move from generalist hospitals to primary health centers. We have specialist referral centers and communities, and this idea of digital innovations, which obviously is going to be taking off, and how we balance wellness and distress and self-care interventions with more clinical approaches without over-pathologizing trauma, over-pathologizing acute stress, and calling it something else, and finding a balance between the non-clinical and the clinical, the biological and the non-biological, and that we account for the social as well. And then there's this exciting question of how technology will be harnessed for mental health care for a pandemic future as well. And I refer you to this paper that several of us wrote last year, which provides really basic underpinning for some of these innovations in global mental health delivery that we can take advantage of with COVID-19. In terms of pandemics and mental health response, the study of pandemic mental health is not something most of us have been exposed to at any time in our training, but catastrophic pandemics have been occurring at regular intervals throughout human history, just not in our lifetimes. Although some have been in our lifetimes, just not where we live. Contemporary psychiatry and psychology have not had a chance to integrate this historical knowledge, except perhaps from the HIV experience. We have some knowledge from TB, Ebola. Consultation liaison psychiatry and disaster psychiatry perhaps come closest to engaging with pandemic response, but there's no real branch of psychiatry or psychology, to my knowledge, that addresses some of the complex concerns. This is from the New York Times yesterday, and just relates to some of the various areas of pandemic mental health that we will start to see things about regarding coronavirus. Unique features of pandemic mental health response include the fact that there's a predictable epidemiological disease model, which we're now seeing in terms of flattening the curve and that we're tracking and that's being tracked for us. The mental health burden on health workers is massive, with both risk of infection as well as psychological trauma. For example, 20% of SARS responders had PTSD in Singapore in 2003. The experience of quarantine with prolonged separation and isolation is an essential aspect of this and a necessary component. The psychiatric and neuropsychiatric sequelae among survivors is something we will be seeing. Behavioral contagion and emotional epidemiology and the central role of public mental health activities is also something that we need to engage with. And then there's a very high relevance of the strength of health systems as protective. I'm going to leave the history to David Jones next week, but in my review of the history, which I've never studied the pandemics, the history of pandemics, and we can see a clear number of events that were really very significant in our history as humans over the past 2,500 years, leading to today with this question of disease X and coronavirus 19. WHO has developed mechanisms for prioritizing diseases for research and development in emergency contexts. And there's also knowledge around preparation for pandemic, which includes paying attention to the importance of culture and planning response, preparing for and anticipating the rising mental health burden, the importance of clear public communications with public health officials, and anticipating various needs, whether psychosocial, grief-related, trauma-related, stigma-related, or the need for disability for affected survivors, affected families, and healthcare providers. And I'd like to propose to my colleagues in the Department of Global Health and Social Medicine that we consider having several working groups, one focused on healthcare providers, and another focused on the history of pandemics and what we can learn from the history of pandemics and apply to mental health interventions in the coming years. There's historical knowledge around social distancing, quarantine, and isolation, that these are essential measures that need to be taken. Two words, isolation and uncertainty, define the experience. Isolation can be both physical and symbolic, and uncertainty can involve survival or recovery, the self, family, or friends in terms of fear of contracting illness, and of course, concerns about the future. I'm going to provide you with some basic information about the Partners in Health emergency response. There's both a long and short-term preparation. The long-term preparation involves years of health system strengthening in collaboration with PIH's sister organizations. The short-term preparation, which has been going on for more than a month now, involves crisis response in collaboration with our 10 global sites and coordination with global partners. In terms of long term, for the past decade and more, 25 years, we've been building teams for mental health service delivery to meet the burden of illness and suffering from mental disorders. We've been building teams for partnership to optimize translation of knowledge to practice from the field of global mental health delivery on the front line. For example, going to Rwanda, where there was a genocide in 1994, it was thought that sustaining psychological, physical, and emotional supports for the victims of trauma had been almost impossible to provide. And given the lack of resources for mental health, it had been a huge challenge. Over the past 10 years, we've successfully developed an integrated primary care intervention where government nurses are trained to deliver both biological treatments and psychological treatments for people living with severe mental disorders and common mental disorders. And that's fully integrated within the public sector of Rwanda in 3 districts. Going to the Haiti earthquake of 2010, what was described at that time was that a lack of attention to mental health services had left Haiti unable or not in a strong position to address mental health after the earthquake. We met with the Minister of Health of Haiti 10 years ago, several months ago, and we agreed that we would try to pilot a community-based model of mental health. And we successfully did that over 10 years. We developed a comprehensive, sustained community mental health system, which over the course of 2017 to 19 delivered more than 28,000 patient visits in rural Haiti. And you can find a link here. This is one patient's story from 2014 about the services that were offered and continue to be offered in rural Haiti. In Peru, we partnered with the government of Peru to develop a number of interventions in mental health and effective collaborations with the World Health Organization. Again, psychological treatments for common mental disorders, biological treatments for more severe mental disorders, social support and assistance. And in West Africa, this is the largest medication dispensary in the country of Liberia. It's a cabinet in our clinic in Harper. Following Ebola, we have innovated community-based mental health care in a number of ways. And ultimately, what we've been learning at Partners in Health through this long-term response to COVID is that we can partner to build back better. We can support ministries of health in actualizing their mental health strategic plans. We can develop community-based services, and we even now can work with governments to strengthen facility-level care and specialized mental health facilities. There's a nice vlog here from John Green in the upper right, and you can find the link and watch a video on our work in Freetown, Sierra Leone. So we've had a cross-site mental health program that has worked to integrate mental health services into primary care systems, focusing on empowering health workers, including non-specialists, to deliver care for both common and severe mental disorders. And we work closely with governments in partnership. We have 4 core delivery activities: clinical supervision and mentorship, program and technical advisement, targeted research support and quality improvement, and data systems. We've bridged effectively with Harvard Medical School, developing a fellowship in global mental health delivery in 2011, and also docking into the Master of Medical Science in Global Health Delivery program at Harvard. And we also have key US hospital partners, the Brigham and Women's Hospital, MGH, McLean Hospital, Boston Children's Hospital. And we have a cross-site team of 6 people. We also have site-based mental health leads. You'll notice of all the mental health leads, 4 have advanced degrees, either from Harvard Medical School or from the University of Global Health Equity in Rwanda. And we also have fellows at the sites, and all are working to actualize the goals that I've mentioned. We're also strengthening partnerships, for example, with the Chester M. Pierce Division of Global Psychiatry at MGH, where I serve as the Associate Director. And we've been implementing a Partners in Health cross-site collaborative and community-based mental health care for common mental disorders that will continue. But this is a platform that will only strengthen our position with regard to addressing the challenges around COVID, both related to patients and also related to supporting staff. And we've developed a cross-site collaborative, a quality improvement collaborative across all our sites. Between 2019 and 20, we had more than 32,000 facility-based mental health visits. That doesn't include community-based visits. 96 PIH-supported health facilities delivered mental health care, and we had more than 5,700 people starting treatment for mental health conditions. I say this because it's really important that we do have platforms for COVID-19 mental health and psychosocial response. And that has been important in terms of working with the sites around their crisis response. Over the past 3 years, we've been developing a Partners in Health mental health service planning matrix to achieve universal health coverage. What this matrix does is it tracks patient experience from entering the system to departing the system. It identifies key areas of intervention and planning for site teams to attend to. There's a health facility component there on the top. There's a community component on the bottom. And on the very top and on the very bottom are other areas, key areas of engagement that we attend to in articulating intervention frameworks and planning and the actual interventions. But I want to direct you to the left, the crisis response category, which is the entry. And so that's where we are with COVID. Our crisis response, which is theoretical based on this value chain, is to use international guidance, including the Interagency Standing Committee guidelines and MHGAP-HIG, response coordination, team development, essential needs assessments, communication and problem solving, using psychological first aid. We did a training today. Our cross-site psychologist, Sacred Kelly, did a beautiful job developing a curriculum, adapting it from the WHO materials, and giving a training to the cross-site teams, to the site-based local teams. Basic management of neuropsychiatric disorders, essential use of medication, and establishment of appropriate lines of referral. I refer you to the Interagency Standing Committee briefing note on addressing mental health and psychosocial aspects of COVID-19, which is a very helpful document. And we are pinning our response on that. And within that, the recommendations include helping older adults cope with stress, supporting the needs of people with disabilities, messages and activities for helping children deal with stress, working with adults in isolation and quarantine, supporting people working in the response. Our actual crisis response has included the following: immediate, regular, clear communication channels with each mental health manager and clinical team at each PIH country site using pre-existing established communication networks. This includes weekly video and teleconferencing, WhatsApp groups, and other digital platforms. We have escalated the frequency and expanded the scope of established monthly learning collaborative that we've developed since 2016, which has been designed for the ongoing sharing of mental health lessons between programs and clinicians throughout the network. For example, the Peru team has trained the Mexico team in Problem Management Plus. The Liberia team has trained the Sierra Leone team in homeless mental health care. We've had other cross-site trainings and support such as that prior to COVID. A cross-site tracker has been created to share daily updates and lessons learned across country sites. We're aligning our mental health strategy with the overarching PIH COVID-19 response strategy, which you can find here. Mental health and psychosocial response priorities have included limiting the spread of COVID-19, sustaining crucial ongoing mental health services and reducing the impact on those already vulnerable due to mental health conditions, reducing or mitigating the mental health suffering and improving functioning of populations affected by COVID-19, and we're actively using that value chain and the Interagency Standing Committee guidelines. Crucial activities include community and facility-based crisis management and referral pathways for mental health emergencies, psychoeducation and basic psychological support focused on the current crisis, medication management for current service users, proactive case management of most vulnerable service users, continued psychotherapy for those with significant functional impairments, maintaining regular clinical supervision and support of non-specialist providers performing crucial mental health service-related activities, and food support for our most vulnerable service users. Other COVID-specific adaptations of our platform: minimizing time spent by patients at healthcare facilities by increasing the duration between visits, especially for stable patients, providing several months of medications to patients as feasible, establishing home delivery mechanisms for medications as well as guidelines for safe home delivery using personal protective equipment in collaboration with the PIH Community Health and NCD teams, spreading out waiting area seating and moving waiting areas outside as feasible, setting up hand washing stations for all staff and patients at entrances to mental health clinics, replacing in-person visits, including formal psychotherapy delivered by non-specialist providers, with telephone visits as feasible. Clinical supervision and support has transitioned entirely to remote supervision via telephone or video conferencing. And the mental health team apologizes for our phone bill. Other proactive outreach to populations includes to active mental health service users and vulnerable population groups, which include those mentioned in the ISC guidelines. And we have lists that our teams are compiling of service users at high risk for psychiatric decompensation, self-injury, relapse, or other safety concerns that have been created, and direct outreach via telephone or home visits are in process to develop safety plans with service users and families in the context of quarantine or positive COVID-19 testing, including supporting patients with basic social needs such as food. And I want to thank all of our frontline implementers who are doing this work, which is a remarkable accomplishment to date. Outreach activities include educational messaging around COVID-19, general coping strategies, and where to find help during the crisis, which are shared with populations using text messaging, radio, and social media. We reached out to some partner organizations, and Peter Ventevogel at UNHCR, WHO, and the IASC reference group has convened a group of us, including International Medical Corps, MSF, Center for Victims of Torture, HIAS, Médecins du Monde, and we've now had 2 intensive calls where we are discussing a template of recommendations for continuity of care, and we're sharing tools and practices with each other. And just to close, here's our overarching messaging. A comprehensive, integrated response to the coronavirus pandemic demands urgent attention to mental health services and care now, with bridging of lessons learned to date across high, middle, and low-income settings, and their repackaging and delivery in community settings by non-specialists using new technologies. Collaborative alliances across systems and funders could be an essential ingredient to urgently actualizing such a critical imperative for local and global health. I'll be talking more with Vikram Patel and Shekhar Saxena about how we mobilize global mental health at Harvard as well for these purposes. The widespread mental health consequences of COVID-19 that will be an inevitable outcome of this crisis should be used to reform mental health care delivery systems in a radical way. The ability of mental health systems and programs to take the coronavirus crisis as a platform to in the future build back better will depend on the effectiveness of our collective adaptability and reaction now. I'm just going to refer you to 10 self-care points that are published on the Partners in Health website. They're published on the website, at the front of this presentation, which you can access through Carol, is my email address. We can discuss self-care. I think that the 10 points have been helpful for people, and really quite universal across contexts. But at the same time, this situation is evolving. Of greatest concern to me right now are the structural issues preventing healthcare providers, including here in the US, from providing care safely, and the very complex mental health sequelae of structural problems that must be addressed. I also wonder about a working group to develop some guidance around policy and advocacy recommendations that can be made to support frontline healthcare workers, both here in the US, at all of the PIH sites, and globally. Thank you.
Beppy, thank you so much for bringing well over decades worth of research, interventions, and collaborations that you've formed to bear on our current situation and to help us moving forward. For audience members, just to remind you to send in your questions that we can give for Dr. Raviola and for Dr. Farmer at the end. And I'll turn now to Dr. Farmer as a discussant in response to Dr. Raviola's talk and given his own extensive experience with the sequelae of pandemics and their impact on mental health.
Hang on one second.
Hi, Paul.
Hey there, Bep. I would say what a beautiful presentation, but I knew it would be, and inspiring as you have been for all these years. I just wanted to bring up a couple of points and to draw on your insights. And I know I'll keep my remarks short this time so that we can turn to the 250 odd people who are listening. I'm not saying the people are odd. I'm just saying I don't know the number. Hold on. Hey there, sorry.
Yeah.
As you can see, I'm following your 10 recommendations of cleaning up.
You look great.
Thank you.
I'm sorry about the phone bill.
Listen, if anybody deserves a big phone credit line, it is you and your colleagues across the world. When you started by talking about health system strengthening, again, like COVID-19, a term that we would not have heard even 15 years ago, I'm very grateful, and I think it's worth kicking this off. I'm very grateful to you and your team spread across the world for doing something more than trying to make health systems equitable. You've also focused on the vulnerable, and global mental health delivery it has been inspired by perhaps the term preferential option for the poor isn't for everyone, but by your insistent and ongoing focus on those who need these services most. I also noticed that you use a soccer metaphor, at least I think it could have been, on your, is on the back foot a soccer term, may I ask?
We're gonna look it up.
Yeah, well, you know, some folks, as you've always pointed out, are more on the back foot than others. And what some of the biggest shortages we still face are the space to do the work, and the systems. And again, for your efforts to address each of those in innovative ways, we're all grateful. And I think I have a feeling that those who have not relied on the mental health team personally or in this region will be turning to it. We already are. I also wonder, maybe David Jones will be able to talk about this, or maybe you've stumbled across in your writings, but in some of these historical accounts of pandemics in the past, there's been discussion of pandemic time, like what happens to our sense of time, how these things stretch out, and how are they compressed. Again, that may seem a little bit highfalutin or far-fetched, but it's something I think that has struck many people, that we're living not only a different time, but temporality itself has altered significance. And as I've said, I'm sure that you've looked at this, and we want to learn more about that. And maybe David can address that. The social contagion theories that you draw on are also fairly new, right? 20 years ago, you wouldn't have heard people talking about the contagion of anxiety or depression or grief, and now we really need to think about that, again, in historical terms, but also in the most pragmatic terms. The expression that COVID-19 gives the lie to global health expertise, or the Lancet letter that says global health will never be the same, I can't help but think again of Scott and David and others who study the history of pandemics. I'm guessing that similar things were said, that global health will never be the same. It might not have been that term, of course, but when pandemic flu in 1918 spread across the world in a similar and frightening manner, there have been accounts that said, public health or medicine will never be the same. And I suspect they were not the same afterwards, in spite of our ability to forget or to shove things down the oubliette. I just can't help making one point, and again, I'm subjecting this to your scrutiny and others on the line. What was said about this in the middle of, or at the outset of this pandemic, which spread across the world in 3 waves, but really in the course of a year, isolation, quarantine, and other containment measures, more than mitigation measures, were applied in a rather unequal manner. When they did not work to stop the transmission, some people call these NPIs, non-pharmaceutical interventions. When they did not work, there was a turn in many places in the world to caregiving, right? To taking care of people, making sure they had nursing care, food, water, shelter, disability. In some settings, that the manner in which containment measures were leavened by caregiving was different from others. For example, in some medical historians who I've been reading and thinking about Ebola, pointed out that the containment over care paradigm, they didn't use that term, but where all the focus was on containment and too little was on caregiving, that those failed in very significant ways. Certainly they failed people who needed nursing care and care in general, who needed oxygen, who needed supportive care or critical care. It was always a mistake, or it is always a mistake, to pull apart the containment response in its varied planks, and the response of the caregivers. And it will be really great to talk with Arthur Kleinman about how we can mobilize an urgent sense of caregiving to inform our endeavors, such as contact tracing, isolation, and quarantine, which is going to include and has included the separation of families. Mm-hmm. It's something that I hope we will become extremely explicit about and learn about, is how do we leaven containment measures with care, with caregiving. And again, you've done that in your own work after the earthquake in Haiti, of course, but also in addressing Ebola in West Africa. And I know that we just have a lot more to learn about that. One thing we could do, if David and Scott and other historians have not, Alan Brandt, one thing we can do is to look back at how these matters were discussed in 1917, 1918, at the end of a war and the outset of the massive pandemic, which a lot of us call the big one. It feels like, and again, pandemic time may distort this, but it looks like and feels like we're in the middle of the next big one now. I had the occasion to look at some of the news reporting from that time, particularly West African newspapers, which were not all run by the British, the French, or the Germans. There were Africans who were the editors and writers who pushed back mightily against containment over care measures. And this comes out in the reporting of the day. In a way, if I could take your comments and say that the disintegration or the pulling apart of containment and caregiving, that represents the biggest threat to us right now. Because it's hard to imagine, working in Massachusetts, for example, or many other places where you've worked, it's hard to imagine pulling apart containment and care and being successful in contact tracing, isolation, and we're required separation of families and quarantine. And we also have a huge literature on this from the tuberculosis prior to the advent of effective combination therapy. And David, I know you're going to talk to us next week, and I'll push you on that. As you point out, and I really do want to close so we can open up, the Partners in Health emergency response builds on a decade of your team's hard work on health system strengthening. And I'm really grateful that you brought that out in your presentation. It certainly reveals the power of partnership, not just partnerships with the ministries of health. These are all in partnership with the ministries of health, but with institutions like Harvard Medical School, the Brigham, the Mass General, et cetera, the WHO. And almost most importantly, it builds on partnership with the afflicted themselves and their families and their caregivers, whether in the formal health sector or in the family, where, as Arthur points out repeatedly, most caregiving occurs. The platform that you describe and you built is still short of staff and stuff and space in which to work and systems, but it's radically expansive and inclusive, what you've all built with your colleagues everywhere. If I look at Mirbalais Hospital, University Hospital, and think about, we just got 20 ventilators donated to us to complement the few that we have and the ones in the operating rooms. And one of the things that we hear a lot in Central Haiti is we just don't have enough X, and then fill in the blank, whether it's staff or stuff or space. We also have to add, yes, but we have more than anyone else does. And that's true not just in Haiti, but in Sierra Leone, Liberia, Rwanda, et cetera. And you've written about this very compellingly in the past. Finally, these COVID-specific adaptations, we'll need these here in Massachusetts, as you know very well. And I know you've been working on that too. And although the expression reverse innovation is much abused and overused, kind of like the term perfect storm when you're describing an epidemic like this, still, I think that what you have described is a robust system to deliver mental health services and prevent growing need. In other words, to flatten the curve of behavioral and social contagion. You've done that in a way that hasn't been done here in the United States yet, and will need to happen. So thank you very much, Bepi and Stephanie and the leaders from all across the world. And I'd like to open it up now, if Scott's agreeable, to questions. Thank you, Bepi.
Absolutely.
Thanks, Paul.
Thanks, Paul. And Bepi, do you have anything you want to respond to directly to Paul first?
No, I really appreciate it.
Great. So looking through some of the questions, one was that works with a community coalition focusing on mental health and racial equity, and they're particularly interested in how mental health care can be facilitated and supported by community members and efforts to support this model. Can you say anything more about what that could look like?
About mental health support by community members.
Yeah, sort of, right, how the mental health workers themselves can work with community members.
Yeah, well, there are all kinds of simple interventions, tools, and practices that anyone can learn. Here in the US, we've had some struggle, I think, with payment systems. And, now with the move to telepsychiatry, there's been this issue of you can't do telepsychiatry across state lines. And but if you look at the slides, which you can get, if you look at that value chain that we've been working on at Partners in Health, what we've tried to do is break down the key interventions at health center and community levels, and then to simplify them in a way that different people can do it. So there's a systems design component to this that's really important, that also factors in the fact that mental disorders can actually be treated, which I think still a lot of people have trouble taking that in. Perhaps, I mean, there's many reasons for that, but there's a lot that community members can do.
Thank you. Please. We had another question by someone who's thrilled to see you online, who is wondering if any of these PIH interventions are being done at American Indian sites as well.
The Navajo site is, they have a very strong and robust community health worker program. It's a tribal program. And there are behavioral health services in Navajo. So yes, I mean, the interventions are, but also the community health workers in Navajo, they internalize and they implement a lot of these strategies in their practice.
Can I just add one thing, Beth? As much as these women, and they're mostly women, almost all women, the community health workers, if you can imagine the challenges before them, and I'm sure, well, you don't have to imagine because you know, but the nation is spread out over 4 states, or it's a vast place, and those valiant women and small group of men number about 115 or 20. Someone else is going to know the exact number, but again, the anxiety I think we'd have, Scott, to whomever asked the question, is that enough staff, and can their systems, can we avoid not running them into the ground because they work so hard already? Anyway, just a thought. It doesn't add to the cheer here, but.
Well, the job was tough before this, obviously, and we probably need to be proactive in reaching out and finding a way to support. So thanks for reminding me.
Beppy, there's a question that, has there been a component of the mental health response to countering stigma, for instance, that against the United States, Chinese, and Asian communities?
There is a lot of passion and creativity from our local site teams in public messaging. And if you look at best practices in pandemic response, which we don't have much experience in, effective public education and coordination with public health authorities is an essential cornerstone of effective response. Not just mental health, obviously. Vikram's hand is raised.
Vikram, go ahead. We're going to unmute you. Let's see. Yeah, 1 second. We're going to. Go ahead, Vikram. I think you can talk now.
Hi, Beppy. Thank you so much for a great talk. Actually, Beppy, I wanted to first respond to on the back foot. That obviously betrays, Paul, and your lack of familiarity with the British Commonwealth. It actually comes from the game of cricket. And I don't know whether I don't think there's an equivalent in baseball, but it's really when anyway, it doesn't matter. But it basically means that you've been foxed by the person who's, as you call it, pitching the ball. We call it, bowling. So thanks, Beppy. That's a wonderful talk. A couple of questions I had for you. The first is really about the longer term consequences. I worry a lot about the fact that while there's an acute crisis that we currently face, but the catastrophic cost of unemployment and penury that face not only millions of people in America, but actually globally. And I wondered whether you could comment that the mental health consequences of this epidemic will far outlive the acute medical ones, and how should we as a department or as a community really respond to that? And the second thing I wanted to ask you was about your sense about how some of the practices that we are adopting very comfortably when we're young, for example, physical distancing, how do you think we as a community can right now respond to the needs of older people, people with disabilities, who are effectively housebound and alone in these times?
Thanks, Vikram. Well, the first question is, we have no precedent for this. And I really would like if we could convene as a department to discuss that and various aspects of it. When we look at some of the mortality data, that before COVID, we were having issues with depression, substance use, opiate addiction, obviously, here in the US. And to imagine what's going to happen with regards to mental health with all of the economic repercussions, it's hard for me to take in. So I haven't gotten my head around that at all, really, because in terms of being on the back foot, it feels like things are changing every 2 hours in terms of the information coming in. I mean, I've stopped watching the news. I get completely overstimulated if I turn on the TV. But I would appreciate if we could convene a discussion on that and what we might do. And that links to the second question, because the isolation of people with disabilities and older adults it's going to be epidemic. And this looks like it's going to get drawn out longer than a couple weeks. So again, I think that there really is a place for caregiving, and also, the reverse innovation concept, but really thinking through how we apply some of the lessons of global mental health in creative new ways using technology, as we've discussed.
Vikram, did you have additional questions?
Okay, thanks, Scott. No, I basically wanted to just concur with Beppy. I do think that these long-term effects are going to be staggering. I think if you look at the data from previous crises of actually much smaller magnitudes, like the crash of 2008, for a good 24 months after that economic crisis, suicide rates of alcohol abuse and alcohol-related conditions skyrocketed. Mm-hmm. And I think with the benefit of that hindsight, I wonder to what extent are healthcare systems preparing for what is almost certainly going to be another epidemic, but in this case of behavioral health conditions. And I think, Beppy is right. I think as a department, as a community in the medical school, it seems really appropriate for us to respond to that. I think that the question about the here and now, I guess, we should feel a lot more confident of reaching out to neighbors in our street that we know are living alone, older people, people with disabilities. I think it probably is something we can do not just as Good Samaritans, but I think as something which fits very well with the values of our department.
Thank you, Vikram, very much. I'm so glad you're with us.
Yes. We've time for one more question. This is a thoughtful question that came from an anonymous attendee. To Paul's point about caregiving, one aspect of this pandemic they're struck by is the degree to which it has disrupted the rights and routines of familial care for dying and deceased patients, people dying alone who otherwise wouldn't have died alone. And based on experience of previous pandemics, what is known about the psychosocial impact of these disruptions? What can we do about them now? Particularly in places and for populations where mitigating technologies may not be widely available or easily used.
Sorry, say that again one more time.
Right. So with respect to caregiving and
Yeah.
and end-of-life care and
Yeah.
social isolation, both being forced both at home and in hospitals, and people dying alone. Have we learned anything about the impact of that long term on family members, loved ones, and is there anything we can do?
Well, I mean, I've got a general question. What experience parallels this that's been recent in higher income countries where isolation has already been a bit of a problem? I'm just thinking about Atul Gawande's book from last year, and just how we think about how we care for and with older adults in the United States. Specifically, I'm thinking about
cytokine storm. Sorry, I didn't mean to be whispering about cytokine storms.
Go for it.
No, I just wanted to say to Scott, to whomever asked the question, that the experience in West Africa, and historically, again, we defer to our historians. The experience in West Africa around this topic was grueling, and the forced end to what were called traditional funerals, or any funerals, the initiation of cremation in Liberia, for example, caused enormous social discord and violence. I mean, in Guinea, the third country affected, Liberia, Sierra Leone, Guinea. In Guinea, there were an average, by the time of December, I think, of 2014, there were an average of 10 attacks per week on the Ghanaian Red Cross burial teams. So, we can look to these more recent events. They're not pandemics. It never became a pandemic. It's not the big one, and I would hope that couldn't happen for a virus that is not airborne. But that was truly one of the most disruptive things. And I think, to Vikram's point as well, and the one that Beppy underlined, we really need to rethink a lot of our our traditional public health approaches as well, meaning isolation, quarantine, burials, and caregiving were the two main sources of infection, and almost always are. And when we think of burial as the last act of caregiving, as it is in, at least in Catholic theology, then we're going to see that we will face this problem, and we have to face it with more resources and more grace than occurred in West Africa.
I want to thank Beppy. I want to thank Paul for not only pointing to the gravity of the problem, but as always, for starting to think around solutions, and both narrow solutions and much larger, more general solutions. So thank you again.
Thanks, Scott.
Next week, sure thing. Next week, as
Thank you, Bev.
As Beppy alluded to several times, we're going to be the beneficiary of hearing from David Jones, our beloved historian, who will really be able to help us think about lessons from the past as we move forward. And
I'm going to bike a book to his house.
Excellent.
Great. Well, thank you everyone for joining us today. And these have been recorded, and we're working on getting them disseminated as quickly as possible. So thank you again.
Scott, if I could say one thing before next week. As difficult as this has been, the idea that we could have a seminar like this, that would not be rare. Beppy has done it many other times, as has Megan, Louise, and others. But we don't get 250 people inside the room and couldn't fit. So I want to thank the much broader audience, and so great to be connected to you all.
Thank you so much.
Absolutely. And shout out there to Jen Pusetti and for Carol Benoit, who really think about the possibilities for these kinds of wider discussions, and just having terrific panelists who can make this happen. So
thank you, Carol.
Great. Yeah. Great. All right. Well, take care, everyone.
Bye-bye.
Till next week.
Bye-bye, Scott.